Awesome. Thank you. Okay, so we're recording. I'm assuming whoever's here can hear me. Once again, yeah, okay. Thank you. Thank you for letting me know. Yeah. Okay, we'll get rolling here. Sorry, just clicking around with my little Zoom screen here. Okie doke. So, as I say, the first two sessions we did in April and in May, they were about the general subject of what's the difference between menopause and perimenopause. You know, what are the different things that happens, what's actually happening to the hormones, estrogen and progesterone, things like that. You can catch that recording. And then last month we talked a lot about sleep and energy and mood and what changes women can expect there. So those are all on the YouTube. And today we're talking about, we're going to talk about cardiovascular health because it's very, very important for more women to be aware of the impact that going through menopause, which is totally natural, has on our cardiovascular system. So our heart and our blood vessels. We are going to talk about the metabolic changes that women experience as well. And when I say metabolic, I'm not sure what you think of first when I say metabolism. I think a lot of people think of weight. It is, I do want to talk about the weight changes because let's not beat around the bush. A lot of women come in and tell me that they've gained weight and they have no idea why. They say they haven't done anything differently and this weight has crept on, and they're also having a lot of trouble losing it. So there are reasons around why that happens, and there are things that women can do to help you feel better in your body and to lose some weight again. And I want to talk about bone health because that might be like the least exciting thing to a lot of women, but it's also really important. And it's a distinct risk for women because of the menopausal transition and the changes in hormones that happen. So I feel like all these things deserve their own time to be discussed. So that's what we're going to do. Okay. So just a reminder, a quick recap. So this slide is showing you a bit of a timeline when we're delineating between perimenopause and actual menopause. So technically, menopause means you have gone a year, 12 months without a menstrual period at all. And then we can say now you've achieved menopause, or maybe you're post-menopausal. So perimenopause is on average the 5 to 8 years leading up to that final menstrual period, and technically for the year after that final menstrual period. And they are different. So generally speaking, the hormone changes in perimenopause, it varies for every woman. Sometimes women go through menopause perceivingly really quick, right? They will say like, my periods were regular right up until they were just gone, right? And other women, they have years of irregularity and years of symptoms, and it can be unfortunately more uncomfortable. So the hormonal transition is a gradual progression to a low estrogen and progesterone state, which is really what characterizes being menopausal or postmenopausal. So when you're in perimenopause, your ovaries, the act of ovulating just becomes slower and less regular, and that affects your hormone levels. And it can cause a host of symptoms or changes that women notice. So that's what we went all into in the first, but I just wanted to remind you here of the sort of chronology of this and the difference. But let's jump right into heart health because I hope to tackle as much of it as possible. So heart disease in women. It's really important. And I do find when I talk about this in my office with patients, I get a lot of sort of, oh, wow, like I didn't know that. It's not being talked about all that much, I don't think. I mean, certainly I've seen women that are aware that they already have a pre-existing heart condition, or something like that. But a lot of women don't realize what changes are happening in their body specific to this. So it's important for you to know that heart attack and stroke is the leading cause of death in women globally and in the US. So more women die of any other cause of heart attack or stroke worldwide. And more women after the age of 50 will die from this too. So it affects women generally more as we age. Cancer still beats heart disease here in Canada as far as leading cause of death, but it's not by much. So I'm not like, when I say heart disease is the leading cause of death and like we need to know about this, I'm not saying cancer is not important, because we know that, you know, statistically in Canada, it still is the leading cause of death, but this is a close second in Canada. You know, so we know it's prevalent. There's a lot of other unique factors, and it's really well acknowledged by leading organizations. Now I see that say like there's a lot of gaps in knowledge when it comes to women specific heart health. 2/3 of the research regarding heart disease and treatments have been focused on men, and men are diagnosed earlier. And it's known that women's symptoms of heart disease are unique, and the treatment should probably be unique. And there's just a big gap of knowledge here. You can raise your hand if you would agree that I find there's often a pervasive attitude that heart disease is a man's disease. I don't know. I feel like we've just seen more images of men sort of gripping their chests, right? Or these kinds of things. But I think there is a stigma, maybe that's not the right word, but still a general attitude that it is a man's disease. From a research point of view, the reason in general so much medical research is done on men and not women is that women have menstrual cycles and women carry children and are often pregnant, and that makes studying women inherently a bit more difficult. So, you know, it's not saying like, oh, like, why couldn't they figure that out? It's just kind of the way it is, but it still deserves to be said that more research needs to be done, and more effort put into understanding how men and women are inherently different when it comes to common causes of illness and death. So heart disease is a big one. So once again, symptoms are often misdiagnosed in women. There's in the research, it tells us that a lot of women's cardiovascular symptoms are attributed to anxiety or just stress, and that leads to undertreatment, which isn't good. So women are often, it's not uncommon for a woman's first sort of event to be like a heart attack, because no issues were identified earlier, which isn't good because obviously the consequences of that are greater. The other thing I want to point out is that in Canada, Indigenous women and women of ethnic minorities have much greater risk than Caucasian white women. It's up to double the risk for Indigenous women, which clearly shows us that there are also gaps in care and in knowledge that should be addressed. And the Heart and Stroke Foundation is actually really impressive, and they seem to be doing a lot on this front, which is great. So risk factors. I put up this chunk here because there are sort of these classic risk factors that we might think of first, right? And these risk factors are not necessarily, like, these are the same for men and women. Like, both men and women are at higher risk for heart disease if they smoke, if you're sedentary or you're not inactive, if you are obese, if you have a family history of heart disease, heart attack, or stroke, if you have high blood pressure, if you have diabetes, if you have high cholesterol. It's not usually just one risk factor that sort of drives the bus here, so to speak. It's often a combination of, but these are classic risk factors, and they do affect both men and women. So those are ones to start with, but the rest I'm going to show you here are pretty much unique to women that we know also contribute to why heart disease happens in women. So once again, being of certain ethnic descent, South Asian, Afro-Caribbean, or Chinese descent, there's an increased risk. Being post-menopausal generally is just thought of, it's an increased risk. It's, you know, it might be sort of chucked down to sort of aging in some language, but really, I believe when you think functionally about the role that women's hormones are playing, between, you know, you had these hormones around in a lot higher levels, and then you went through this natural transition, and now they're a lot lower, and that will affect the health in that system. Pregnancy is a unique risk factor for women. Any woman that has been pregnant, and if it's just a lot of stress and work for the body, and especially if women experienced high blood pressure when they were pregnant, or if they develop gestational diabetes, which is a form of diabetes that you have when you're pregnant, that will put you at even more increased risk. So I always ask about that and want to know if women in their history have experienced those conditions, because it might mean that, to me, it's important to check their blood sugar again when they go through menopause, check their control there, have a blood pressure assessment, whatever it may be. Women's exposure to oral contraceptives, which are hormones, and any other kind of hormone treatment, replacement therapy. That's what HRT stands for, hormone replacement therapy. In general, it's thought that there's a slightly increased risk from this exposure with oral contraceptives or the birth control pill. Notably, there's an increased risk for women depending on the kind of blood clots, which can cause strokes. And this was publicized, like there were cases of young women throwing these blood clots and dying when they were taking birth control. We know the risk is much, much higher when women smoke. There's a huge risk if you combine certain oral contraceptives with smoking and that risk. And there's some other family history involved there, but I just wanted to make note of that. I also want to mention autoimmune disease, which really predominantly affects women. Like women are way more likely to have forms of autoimmunity. And it is also something that increases risk of cardiovascular disease. So autoimmunity, like things like rheumatoid arthritis or lupus, those are some big ones that I know in the research, they have shown that there's like a significant risk in those women having a cardiovascular event at some point. It really has to do with inflammation. So in autoimmunity, there's persistent inflammation, and that inflammation is a really, it's a significant driver of vascular disease. So once again, women, we need to know this. We need to know if this is in women's history. And I just think we need to be more proactive, especially in women with some sort of history of chronic inflammation or autoimmunity, so that we can, do more to mitigate that inflammation. And that affects their health, not only in their heart and blood vessels, but broadly as well, right? Polycystic ovarian syndrome, or PCOS, during the reproductive years, it's actually the most common cause of irregular periods in reproductively aged females. And it's a very common cause of infertility or challenges conceiving. It's basically where you don't ovulate regularly. And it's a syndrome because it's a collection of hormonal changes, but we do know that women with PCOS in general have a higher risk of having heart disease later in life due to the sort of picture there. So once again, I'm always trying to be really proactive in women that I see with PCOS, so that and supporting them adequately when they start to go through the menopausal transition to support this part of their health. Infertility treatments, they're so broad and varied, but once again, some of them have been linked to increased risk in women, so that's unique to women. Breast cancer treatment, depending on the treatment, the kind of chemo that's used, even certain hormone-specific treatments, it can once again increase the risk. I mean, I'm not saying it's not necessary, but I just think it's once again unique to women. And then depression and anxiety are considered unique risk factors for heart disease. In women and in men, but more so in women, the research shows. And women also, we just have generally smaller blood vessels. So there's some early suggestions that once again, women's blood vessels are potentially even more sensitive to the buildup of things like cholesterol and inflammation and calcium in them. We need to do more research here, but I know that there are specifically cardiologists that work on this subject specific to women. So the signs and symptoms of a heart attack, if anyone wants to throw it up into the chat what they think of first. Once again, I mentioned that there's often, a certain image of what someone looks like when they're having a heart attack. I just want to go over what those symptoms are. So of course, I'll lead chest pain and or discomfort is a classic one. And it can be acute, or if someone develops new chest pain or discomfort that's more persistent for a certain amount of time, it should be brought up with a doctor. It can be a varying intensity as well, right? Women can have more discomfort in the neck, in the jaw, in the arms, the upper arms, maybe particularly the shoulders, the upper back, the stomach as well. So any kind of discomfort there, once again, that's new or worsening, should be discussed with a healthcare provider. This is a big one, and I've seen this in some women where they had persistent symptoms more of like digestive issues. So they had heartburn or like gastroesophageal reflux symptoms, even nausea I've seen, and they did seem related to eating. But, you know, always these symptoms, if they're new or if they're worsening or they're very persistent, and especially if they don't respond to the typical treatment you would give for those digestive things, you need to be worked up for cardiovascular issues, because I've seen women where it was determined that they actually had blockages in their arteries and it was producing those symptoms. So that's an important one to mention. And it does seem to happen more to women, that they'll feel it digestively, but it's actually their heart. Sweating is another symptom, lightheadedness, shortness of breath, and the shortness of breath can be with exertion or at rest. And unusual fatigue is another one. So I just encourage women, you know, I just want you to be aware. I want you to, you know, trust your gut. If something is new or doesn't feels unusual to you, it's always, you know, better to be safe, and discuss it with a doctor or be seen by a doctor. I wanted to mention the symptoms of a stroke as well. Maybe some of you have heard of this Be Fast acronym, which reminds you of the things to look for. And this does help save lives. Basically, a stroke is a blockage in a blood vessel in the brain. And so it will cut off the blood supply to the brain, and it will affect potentially balance. It can cause blurred vision. It can affect drooping of the face, or basically like a weakness of one side of the body. So sometimes, you know, you can see that weakness, or you might ask someone to raise their arms, and if they can't raise both, then that would be concerning. They might have speech difficulties, slurring, or just like an inability to talk. And then basically any one of these, it doesn't have to be all of them, any one of them means you call 911, because treatment, the faster the better when it comes to a stroke, as far as dissolving that clot, and then hopefully having someone recover from that. So we talked about heart attack and stroke. Once again, a heart attack is a blockage in the artery that supplies the heart. That's what those, you know, chest pain or jaw pain or upper arm pain, those kinds of things. And then the stroke is a blockage in the brain. And I should remember, when I say heart disease, the most common causes of death are heart attacks or strokes, but there are, you know, there can be women that are born with congenital heart conditions, or maybe they develop a valvular condition. Maybe they develop an arterial condition, right? So there's other forms of heart disease, but the most common causes of death or disability are heart attack and stroke. So I wanted to spend more time talking about that. So we mentioned this, that heart disease is the leading cause of death in women in the US. It accounts for over a third of all deaths. I also want everyone here to know that the numbers jump up even higher in post-menopausal women after the age of 55. So in general, the older we get, the risk goes up. In women who experience an early onset of menopause, so your menses or your period stops before 40 years of age, there's an increased risk for those women, even more so than a women that went through menopause at 50 or 51 or 52, more of those average ages. So any women that goes through menopause before 50, you should have more of a discussion about what's being done preventatively, and how are you getting a baseline to understand your health on this front to begin with. So early menopause is a significant risk factor when it comes to heart health. Also, when it comes to bone health, also when it comes to brain health, any women that goes through menopause early, you deserve to have a lot more of a conversation about what you can do to support your health there. In general, what I'm saying is that there's a lot of benefit to women continuing to have ovulation and ovulatory cycles because of the hormones that we produce in that stage. So when that goes away early, and maybe for some women it was necessary because they required treatment for a cancer, or they had to have a hysterectomy because of a pelvic condition. But there still needs to be more support, understanding that that will affect the hormones sooner for that woman. So surgical menopause is included there. We know that there is a slightly higher risk of cardiovascular disease in women that had surgical uterus or ovary removal. And once again, unfortunately, a woman's likelihood of dying from a heart attack after menopause is a lot higher than when you were premenopausal. I think, once again, this is probably a number of different factors. It's probably due to not a lot of assessment, maybe not understanding the symptoms, and then the first time they present is with a heart attack. But the other thing to think about here, so not just to chalk it up to aging, the reason, and this is once again what makes women unique, is that estrogen is having a lot of effects on our cardiovascular system. So we have a bit of estrogen when we go through menopause, but not nearly the same amount. And once again, this is a natural transition. But having said that, there are a lot of these camps that now the argument for giving women more hormone replacement is an argument as far as the protective side of things go, because we know the effects it was having, and women are living longer in a post-menopausal state. So what are we doing to be preventative and improve the quality of life that women have in this new lower estrogen place? So when it comes to our heart and our blood vessels specifically, estrogen, which is estradiol, that's the most powerful form of estrogen in our body, it has a number of effects. So it's an antioxidant. It causes relaxation of the muscles within the blood vessels, which affects blood pressure. It produces something called nitric oxide, which basically keeps the blood vessels nice and open. This is given to people when they have angina or they're having spasms of the blood vessels. It has, in general, anti-atherogenic effects, which means that it decreases the buildup of material within the blood vessels. And basically, buildup of material in the blood vessels is what causes blockages, which is what causes loss of supply, which is either a heart attack or a stroke commonly. So it's protected that way. It regulates platelet function, which, once again, if there's a lot of platelets that just stick around, they'll clot, right? And basically that's a blockage. So there's a number of effects that we know estrogen has on our cardiovascular system. So we can appreciate already, we go through a change where it was a lot higher and now it's come down here. It's going to change these functions. So once again, we can see that a lot of women will have an increase in cholesterol levels. So estrogen seems to be playing a role in modulating cholesterol levels, which is notably triglycerides. Something called low density lipoprotein cholesterol will push up a little bit, and slightly decreased HDL cholesterol, which is considered good cholesterol. Now, cholesterol and having maybe quote unquote high cholesterol is not the only risk factor when it comes to heart disease. But it is one of them. And we do see that women in general are more likely to have increases here naturally because of the menopausal transition. When we have the loss of estrogen, in general, is an acceleration of the buildup of both the cholesterol or fat, inflammation, and also to a degree of calcium in the blood vessels. So all these things together, inflammation is a real kicker when it comes to sort of accelerating the stickiness within the blood vessels. I think that's an important one to remember, and I'll mention to you some tests that can be done to help understand that better. And once again, that's why autoimmunity is so important to acknowledge and incorporate in someone's wellness plan, because more inflammation, right? Women with severe and persistent vasomotor symptoms, so hot flashes and night sweats, are thought to be at even greater risk of heart disease. And this may be that, like, if you've gone through menopause, but like for 3 years you had like really bad hot flashes. It's not really understood why this is, but there just seems to be a correlation. So I just think, once again, what that means, if I see a woman that's having like brutal hot flashes, which not every woman does, I'm going to be, I definitely would want to get a baseline for her heart health, understand, like, do you have high blood pressure? Where's your cholesterol at? Any diabetes risk factors, all these kinds of things. In general, our arteries, when you think of estrogen or think of aging, you do tend to lose elasticity. So things can become a bit more rigid. And that seems to be accelerated when we go through menopause. And you can think of that too in your skin and in your joints, like those things are affected too by the loss of estrogen. But this can affect blood pressure levels once again, and just sort of like the resiliency of the blood vessels. And once again, if they're really small, and then you couple that with any buildup or blockage, it might be a bit more problematic. The other thing that hormones and the changes in hormones affect is often blood sugar control. And changes in estrogen progesterone can result in something called insulin resistance, which we're going to talk about more with the weight related concern. It's not uncommon for women to gain some weight, especially in the midsection when they even perimenopause, but once they've gone through menopause as well. So the hormone change does affect the way that the hormone insulin works. And that is another thing to consider. I want to remind people too, I think I mentioned this at the last session because it was sleep specific. Sleep apnea is more common in women when they around the menopausal transition. So it's more common to be diagnosed then. It can happen in younger women too. And you will see, this is a questionnaire that I will often give to people or sort of do with people if I've heard any sort of red flags for sleep apnea, which is basically like, it's like you stop breathing and you have erratic breathing patterns when you sleep. And there's a known correlation between sleep apnea and increased risk of heart attack in men and in women. But so I just don't want women to be forgotten here. We use the stop bang acronym. So do you snore loudly? Does your spouse tell you you snore? Can people say like they can hear it through a door or something like that? Is it new? Is snoring new for you? If there has been weight gain and the snoring comes with that, that's a red flag for sleep apnea. Do you feel tired, fatigued, or sleepy during the day? Has anyone observed you actually stop breathing when you sleep? I've had patients say, yeah, my husband said I stopped breathing and it was pretty scary. Are you being treated for high blood pressure? You can see there's an increased risk in the bang part. If you're male, that's circled yes, and that contributes to a point. Age in general, having a higher BMI, and then neck circumference. But this is something that both men and women should be assessed for. And once again, treatment is generally, you have to do a sleep study. If you scored intermediate or high here, I would say you need to get referred for a sleep study, which is where they actually clinically determine that, yeah, you do have sleep apnea. And then they would set you up with a CPAP machine to keep your breathing regular when you sleep. And when I've seen women start with this, they feel so much better when they get started with treatment here. So I can't refer for sleep studies as a naturopathic doctor, but I've told my patients, like, I want you to talk to your doctor about this, and then they've gone from there. So I wanted to mention that. Now, when it comes, so I've mentioned that there's HRT, hormone replacement therapy. So that's the use of estrogen and progesterone. And we talked about that in the first session as far as it treating things like hot flashes. We talked about it as far as helping with sleep. We've talked about it for concerns like vaginal dryness and atrophy. So there's so many different quality of life things that hormone replacement is used for, therapy is used for. And then it might be a bit more silent when we're talking about its protective effects in women. And we do know that there is research to support its use due to its effect on the heart and blood vessels. So remember what the things estrogen was doing. Progesterone as well is uniquely protective to the blood vessels, and progesterone tends to also decrease blood pressure. So there seems to be more benefit to the heart and blood vessels for women who use hormones early in the menopausal transition. So what I'm saying is within 1 to 3 years after their final menstrual period, there's more benefit. It kind of makes sense. And this is the same too for bone health. And I think we talked about it with respect to mental health as well, and like prevention of dementia and Alzheimer's. The research always shines better when it's used closer to the transition versus a woman who didn't take any, and then maybe they're well into their 60s and now they're interested. We just have to weigh out really properly the risks versus the benefits and what sort of weighs out there. But it makes sense because when you go through the transition, your body is perceiving sort of the biggest drop, and the changes that happen then are just, they're a bit more accelerated. So the hormones help stabilize that. And the goal of hormone replacement is not to make you 25 again. It's not, but it's just to bring the levels up a little bit into more what we would call a physiologic range, where the impact and the health promoting properties of the hormones are seen again. So HRT, unfortunately, in the research probably shows that there's no to little protective effect in women who begin using them later. It's still being evaluated. I would say more research needs to be done, and it doesn't mean it's an absolute no. I find a lot of conventional doctors might be like, no, we don't do that. I think once again, you need to have a really good conversation and weigh out the risks versus the benefits. HRT is associated with a slightly increased risk for women who initiate it in their 60s. Especially in the first year, there seems to be a heightened risk of blood clotting activity due to giving a woman estrogen again. And if a woman has pre-existing coronary artery disease, so any buildup in the arteries to begin with, that risk will be even more heightened because there's typically a bit more clotting happening when we give women hormone there. What that tells me is that if you're in your 60s and you want to take hormones for some reason, you should have a thorough cardiovascular health screening before you do so. Bioidentical progesterone, a lot of the negative risk when it came to hormone replacement therapy and heart disease came from the use of something called progestins, which are in birth control pills, but often given to women going through menopause as well in combination preparations. Progestins have a higher risk than bioidentical progesterone does, which means progesterone is the compound that your own body makes. So there is a difference between what we might call sort of synthetic hormone versus hormone that looks exactly like what's in your body. We need to have more research done here, but in general, what I have read suggests that progesterone is actually protective from a cardiovascular point of view versus increasing the risk slightly when we give a woman a progestin. So I just wanted to mention that, and that's part of the conversation I have with women one-on-one when we're discussing hormone replacement therapy. Okay, so heart health, and there's going to be overlap. We're going to talk about food and how you nourish yourself, but let's get into the weight. And I feel like it segues well because once again, weight and the weight gain that happens is sort of another risk factor for heart health, right? So let's get into that. It's not uncommon for women to once again come to me being like, I don't know what's happening. I feel like I haven't done anything different, or maybe even women have, and they're like, why am I doing this? And it's not changing the way it used to. So the unfortunate truth is that the hormone changes you experience do affect your metabolism, which will affect in general how you store fat, where you store fat, and also what allows you to lose it. So I want you to understand that better, and then that will help give you a bit more confidence, hopefully, and ease when the subject comes up. So where you carry weight tends to change in women when they go through menopause. So from a female to a male pattern weight carrying, which basically means you're more likely to put on extra weight in your midsection. So you'll be more of an apple versus a pear. Estrogen likes to give direction when it's higher to have weight settle on the hips or the buttocks, the breasts and the chest area too, and sometimes it is all over. But in general, when it goes away, we tend to have an increased deposition in the midsection. And that weight there, it's riskier because it's more likely that we can have an increase in what's called visceral fat, which means fat around the organs. So there's like superficial fat and then there's deeper fat. So there are ways to once again lose that, but that's the loss of estrogen tends to speed that up to a degree. In general, your resting metabolic rate, or basically like the rate at which your body is burning energy, will just go down when the hormones drop, which means it does mean that you don't need to eat as much to run your body. There is still, I think in general, there's still a bit of a consideration when it comes to like calories in, calories out. But the reason that a lot of women will do that, and I still get women that are like, they'll do Weight Watchers, or they say they're tracking everything, and it's still not working. It's not the only factor. We don't want to forget about it completely, but it's not the only thing. In general, though, that metabolic rate just gets turned down. And once again, it goes down, and that affects, it means that it's like you need to eat less. and move even more, right? Or consider, like, once again, how are you getting energy out? Food intake can go up as well, especially I find when women aren't feeling well. And, I think that this is driven by a number of things. I can see it a lot when women are really sleep deprived. We know from research too that we tend to make poorer food choices when we're sleep deprived. We'll reach for things that are faster sources of energy, more carbohydrates, more sugar, more caffeine, maybe some more alcohol in some women, and that doesn't tend to help. So I find that when people feel well, they're more motivated and likely to have better nourishing habits. So that's another factor. I mentioned that the loss of estrogen does affect hormones that regulate blood sugar control. So insulin is a hormone that every time we eat, insulin rises in the bloodstream, and it allows our sugar, which is coming from our food, to be taken up into the cells. So a diabetic is someone that doesn't have enough insulin to do that, or their insulin has stopped working. And so they can have high blood sugar levels because insulin gets the sugar to be taken up into the cells. Insulin resistance means you're secreting the insulin just fine. It's actually too much insulin is the problem, and your cells are not listening. And insulin is a storage hormone. I'm going to say that one more time. It's a storage hormone. When insulin is out and high, we are in fat storage mode. You will not lose weight if you are in that state. And so the way that we generally regulate this is when we enter into stretches of fasting. So sleeping is the first example. Our insulin is nice and low. That's what helps us lose weight. We have to achieve times where our insulin is not high to actually be in a weight loss mode. Because every time you eat, it's going to come out to a degree. But if there's insulin resistance, which means your cells get tired of hearing it, and now you're going to kick out more insulin, you're driving even more fat storage there. So this is a common thing that I see. I test for it. I'm going to come back to how we test for it. And there are specific strategies we use to address what's called insulin resistance. It's really an important thing for me. And I do see it happening a lot to women when they're perimenopausal or menopausal. It seems to come up more. I see it in young women as well. Don't get me wrong, but it definitely needs to be considered in women midlife. The other thing is cortisol. Cortisol is a predominant stress hormone. We release it every day. It wakes us up, it's alerting, it allows us to do all the things we need to do in a day. But from a stress hormone point of view, we want to have nice periods of rest from cortisol, just like we do from insulin. And if we are in a state of chronic cumulative stress and we're calling on cortisol production more, it creates a big, hot, soupy mess of factors that will also cause weight gain in the midsection. Cortisol loves to tell you to save your fuel in your midsection. In general, what you can think of is when you perceive stress, your body's really smart. It's like, okay, we're stressed. I need to conserve energy, right? I need you allowed to do the things that you have to do and prioritize those, which is thinking, moving, running away, whatever. But for the rest of it, I'm just going to have you hang on tight, right? Because, I'm not really sure when I can sort of let go of things there. So we always want to think about that too. There's been research that examines the difference between premenopause, the menopausal transition, and post-menopause, and the body changes that occur. So there seems to be a steady increase in weight, in fat mass, and in BMI that begins 5 to 8 years prior to a woman's final period. So what I'm saying is that the weight can start to creep on for a lot of women before menopause. And I've heard this in practice for sure, where women are like, no, I'm still having regular periods, but this weight, like, where did it come from? Accelerated changes in fat mass increase, and there's a lean tissue decrease that occurs in the 4 years around the final period. So what I'm saying is approximately the 2 years before and the 2 years after your final period, that's where the quickest change happens. And it's kind of a double whammy. So you get more fat, but you also lose a bit more muscle. Muscle is more metabolically active. More muscle you have, the higher sort of energy burning rate you will have. And the less muscle you have, the lower your metabolism is. So we want to try to help women maintain more muscle, Okay, that's generally helpful from a weight perspective. And it might not be the number on the scale, but it will be how you feel in your body. And that also has to do with like strength and bone health and in general, just well-being. So it matters for a lot of reasons. Now, the changes to body composition slow down after menopause. A year or two after, they'll start to slow down. So everything is heightened right around the big show, and then it steadies out again. So this visual here shows you that. So you can see in general, like it's like fat mass, proportion fat, total body weight. What it's showing you is that like 0 is the final menstrual period, right? So it's creeping up more before that final menstrual period, creeps up a little bit for like 1 to 2 years after, and then we level out again, generally. So I've talked about this insulin resistance piece. As I say, the cycle is you eat food, you produce insulin, you make insulin in your pancreas. It's secreted. Ideally, all your cells go, oh, there's a bit of insulin. Thanks. It fits like a key in a lock onto your cells. And now the sugar that was in your bloodstream from the food that you ate gets taken up into the cells. So again, we don't want sugar floating around in our bloodstream, right? That's problematic. That's what a diabetic is. So it does that, but your cells are not listening very well. And in general, once your cells and your brain and muscles have what they need, anything left over is fat. Anything left over is fat, right? And the more insulin you make, the more you're directing storage to fat. And in general, it likes to predominantly put it in the midsection. The other thing that is a sign of insulin resistance, so kicking out more insulin than we ought to after we eat, is that you feel tired and hungry after you eat. And then there's a bit of a vicious cycle because often when we're tired and hungry, we go, okay, I'm going to eat again. So now insulin comes out more, right? And then we're in a bit of this cycle. So the good news is there are ways to break it. There are ways to assess for this, which I think is really valuable, and it's not expensive to do that. And this is what I do and talk with a lot of women about. So hopefully that makes sense. I mentioned the cortisol, that stress hormone. This idea is stress spelled backwards is desserts, meaning when we are under more stress, emotional stress, perceived stress, whatever it is, once again, our body's smart. It knows what it has to do to survive. It's, our brain is not very good at delineating between like an actual physical stressor and us, just perceiving like, okay, I've got to call this person and it's getting me all worked up, right? Or, just like we can totally dream stress up. And unfortunately, what it just means is that to our brain, it can't delineate the difference. It makes the same response. So stress is very individual. It's very cumulative, and it's not realistic to not have any stress. We all have it. But I talk a lot about this with women because I see a lot of women wearing a lot of different hats. I see a lot of women putting everybody else first and putting themselves second or last. And I think that builds up. And then when their body goes through this big transition and change, it's like gas on a fire, right? And everything just gets heightened and feels a bit out of control. So we need to be real about the stress piece. From a metabolic point of view, I do just find with a lot of women when they're really bothered and the weight loss is really difficult to shift, we have to think about the stress hormones and how much they're affecting things for her. So cumulative stress is a problem if your body is lacking the resources and the resiliency to manage the impacts, which once again is like, it's usually because it's been going on for a long time. So this is not a woman's first sort of rodeo with stress. And like she's an amazing person. She's doing all the things and she's wearing all the hats, but it's kind of at the sacrifice to her body working as well and as optimally as it could, right? It's keeping her alive and it's keeping her sort of like doing it, but it's not helping her feel her best. That's for sure. I'll put it that way. So it's not all bad. Like we need this to a degree, but in general, persistent secretion of stress hormones tends to get in the way of our production of progesterone, estrogen, and testosterone. It tends to disrupt our sleep patterns. And once again, if we're sleep deprived, we tend to make poorer food choices. We tend to need more caffeine, these kinds of things. Cortisol tends to cause, in general, when you release stress hormones, you need to release sugar to follow it because your brain is saying, you're stressed, you need fuel. Let's release some sugar. And now you need insulin to follow it. right? So it can create a bit more of a pressure on that system. And in general, persistent cortisol also disrupts thyroid hormone activity. And a lot of women come in and they'll ask me, like, I'm really hoping that you're going to tell me my thyroid is to blame here because I need something to pin this on. It's not quite as simple as that. I've mentioned before that I think thyroid assessment is an important baseline workup for every woman in perimenopause and, going through the transition. But we want to look at the labs first and understand what are your symptoms and figure it out from there. So yes, it can be a factor when it comes to weight for women, but sometimes it's not. So it's not a rule. Thyroid conditions are under-assessed in women. And so once again, every woman deserves to have that tested for sure. And stress hormones also contribute to brain fog, memory, mood as well in the long term. So there's so many different impacts. Yes, it has an impact on where you store energy, and we don't want you to store more than you need to in the midsection. Okay, so what can we do? We need to increase the feeling of fullness. And this has a lot to do with that cycle of, like, if your insulin's higher than it ought to be, then it makes you feel tired, and then you're hungry again, and you have more of these highs and lows in your blood sugar. We can help sort of stabilize that by increasing a feeling of fullness by focusing on protein intake. Adequate protein is so important. You're going to hear this come up a few times. We need to eat enough protein as women, and I see so many women underdoing it with protein. It says 1.5 grams per kilo. I used to tell people like 1 to 1.2 grams per kilo of your body weight. So literally you can take your weight in kilos and multiply it by at least 1.2 to figure out how many grams of protein you should be eating in a day, divided up throughout the day. So an example for me is like, I need at least 80 grams of protein a day, right? And I find most women, I'm telling them that they need at least 75 grams per day. And a lot of women are undershooting on that. So not enough protein will affect your muscle mass. It affects your blood sugar control, and it will make you hungrier and tired. Okay, so protein is really important. We're going to come back to that, but that calculation is a good one to have. Fruits and vegetables. Are you shocked by this? I'm sure you're not, right? No one ever got sicker by eating more fruits and vegetables. I would make that argument anyways. I know there's some people out there that are touting a carnivore sort of diet. I personally do not. I think fruits and vegetables are fantastic, but increasing fiber also helps us feel full, and it's very balancing to our blood sugar. So instead of this, we get this, which is better from a metabolic point of view. We want to ensure that we have an adequate fasting window, once again, from the point of view of that insulin. So when we fast, insulin is low, or it should be low, to accomplish goals. So this can be as short as a 12-hour window. That's like usually the best way to do this is like, think about when you sleep. So if you go to bed at 10 p.m. and you're up at 6 or 7, this is where intermittent fasting, the idea of sort of stretching that fast and not eating right away, it can help some women achieve weight loss. And it does, in the research, tend to show that it will lower high insulin when it's too high in the fasting window. What I would say with intermittent fasting, which is once again the practice of sort of stretching a fasting period and then eating in a smaller timed window, so eating in like a 7 to 8 hour window, it doesn't work for everybody. And if you try it, you just have to acknowledge, like, how do you feel when you do this? Does it make you more anxious? Does it make you hungrier or reach for poorer food choices? Just whatever it is, how does it make you feel? If it doesn't make you feel good, then don't keep doing it. The relationship between fasting and some women, I find with especially more stressed women, it will be perceived as more of a stressor, which is not a good thing. But we basically want to help encourage lower insulin levels, right? Things like foods like olive oil, nuts, and you don't need to eat a truckload of nuts. I'm talking like 2 to 3 handfuls a day. Things like soy protein and whey protein, those are all good ways to up really healthy fat and healthy sources of protein, which once again are filling, regulating to blood sugar, really helpful that way, good sources of protein. I think that we can all often benefit from having an accountability partner. So whether that is, on a movement-based front or someone that is working with you to set sort of little workable goals and help you work towards them. That can always really help. I think it's all about small, achievable, and sustainable steps forward. And I really hesitate to use the language diet because I think there's so much attached to when we say diet, we think restriction, which backfires for a lot of people. I talk more about how we want to nourish somebody and how we want to functionally support our body when it comes to these lifestyle changes. Now, when it comes to hormone replacement therapy and weight, I've had women come to me with the concern, am I going to gain weight if I take hormones, right? Maybe that's for their hot flashes or for their sleep. The research has not demonstrated that. I would say women are different, and I have seen some women, depending on how hormones are given and the balance between them, where it can affect weight. I see this a lot in women that take birth control when they're younger, and they'll tell me, I really didn't like taking birth control. It made me gain all this weight. So I have seen it, but the research doesn't quite stack up. I just tend to listen to women and believe what they tell me there. There have been some studies that show that estrogen replacement around menopause improves body composition in women. And so that makes sense because the loss of estrogen causes insulin resistance. The loss of estrogen tends to have us resettle weight in the midsection. So if we give a bit more of that, it alleviates some of that. So I can't say that, oh, that means that like it's as simple as just, let's just give you a bit of hormone, right? And that'll take care of it. We still have to think about how you're eating and nourishing yourself. We still have to think about movement. We still have to think about stress. We still have to think about all those things, right? But there is some research that shows a positive change for women in their body composition when they're given hormone. It's not a rule, but it is there. So I mentioned the protein piece. That last slide said 1.5 gram per kilo. I would say, once again, at minimum 1 gram per kilo. 1.2 is probably a sweet spot. If women are really active, any endurance activities they do, like cycling or running or anything like that, they have higher requirements. So shoot for 1.2 grams per kilo. Once again, take your body weight in kilos and multiply it by 1.2, and that will tell you how much protein in a day you need. Protein plus fiber plus fat equals balanced, stable blood sugar. So the opposite of this, which has you on a roller coaster of sort of, whoa, we come way up and then we crash down, is just eating sugar, right? So that's eating a chocolate bar. Or it is eating carbohydrates that release sugar very quickly. So carbohydrates that release sugar quickly are any of your white flour, refined carbohydrates, white bread, white rice, pasta is pretty quick. Basically, the less fiber there is in a carbohydrate, the quicker the sugar is going to be released. So anything with higher fiber is always better, okay? So it's important to remember that. And fiber has, we've talked about fiber. Fiber comes up from a gut health point of view, bowel regularity point of view. Fiber and protein, so important. And I think you can achieve a lot of that by eating a lot of plants and understanding where plant-based protein comes from, and then supplementing that with animal sources as well. So fats, protein, fiber. Fats and proteins technically are the nutritional backbones of all of our hormones, and also things like serotonin, which affect our mood and our brain health. That's really what we build those structures from, are fats and protein, which is why they're so essential. I've mentioned the protein things. Fats, don't fear fat, and don't fear fat from a cardiovascular point of view. I think this has largely been debunked. It really depends on the kind of fat. In general, animal fats or saturated fats, which means they're solid at room temperature, carry more risk than unsaturated fats, which generally come from plants, right? So don't fear fat. I'm not someone that fears fat. About a third of your total caloric intake should be from fat. So if you eat, I'm giving you an estimation, if someone eats 2,000 calories per day, that's 75 to 90 grams of fat in a day. Ideally, you want to get fat from, Evo is extra virgin olive oil, so cold pressed olive oil. Fish and fish oils. So fish oil supplementation is something that often I will discuss with a lot of people. I just find a lot of people, myself included, don't eat fish as a regular part of their diet, fish or seafood, which is such a good source of these unique fats called omega-3s. And they are very heart healthy fats, and they're very good anti-inflammatories. And they have lots of benefits on mood and brain health. So I myself take a supplement, a good quality supplement. And I think a lot of people, often people come in to see me and they're already taking one, right? And then I'm just talking about the proper dose for them, depending on what the goal is. Avocado oil is another good oil I tend to keep around. I think it's really good for cooking. I think extra virgin olive oil is best eaten raw or not heated because it's not as heat stable. Avocado oil or coconut oil is good for when you want to heat an oil. Flax seeds or flaxseed oil, very good source of healthy fat. Flax seeds, when they're ground or whole, are also a great source of fiber in addition to the fat. Always keep flax seeds stored cold. They're very temperature sensitive. The oils in them go off very quickly if they're not cold. Chia seeds are another great source of fiber and healthy fat. Once again, I tend to store them in the fridge to keep them really fresh because the fats are sensitive. You'll find that with a lot of plant-based fats that they're not as stable at higher temperatures. Coconut oil being the one exception. So coconut oil is a sort of solid fat. And then if it heats up, it becomes liquid. That's normal. It is not a totally saturated fat. It's what we call a medium chain triglyceride fat, which is a bit unique. So it's kind of in its own class. But in general, any sort of plant fat from a nut or a seed, keep it cold, keep it dark, and don't keep it with an open top. If it's an oil, keep it closed. So oxygen, light, and temperature are the big three things that make fats basically go off, right? Nuts and seeds, once I mentioned, like 2-3 handfuls a day is what you need. Ideally, I recommend that we choose raw nuts and seeds without added flavorings or added salt or added sugar or whatever it is. So munching on walnuts, almonds, cashews, pumpkin seeds, those are some examples I can think of. And then I'll mention dairy too. And when it comes to dairy, I just tell women, I'm like, go for the fat in the yogurt. Go for, I think we can keep our amounts moderate, but don't be afraid of the fat. Be afraid of the sugar, the added sugar there. Calcium-rich foods. Calcium is, we often think of dairy first for calcium. So milk, cheese, yogurt. Yes, it's a good source of calcium, but there's also nuts and seeds, sesame seeds, almonds. Chia seeds are another really good source of calcium. There's lots of vegetables that are surprisingly good sources of calcium. Fish, especially eating some fish where the bone, like salmon with the bone in, is like an exceptionally good source of calcium, right? So you can get it from other foods. And I think calcium-rich foods are great. And then with a lot of women, what I end up discussing is that they probably don't need as much calcium from a supplement that they think they might, right? So I don't think I've ever prescribed more than 600 milligrams of a calcium supplement to women, because I really think most women are getting, at least that, if not more, through their diet. And you can take too much calcium from supplement and diet combined. And if you take too much, it sticks more in your blood vessels. And that's a bit problematic. So we want to strike the sweet spot when it comes to calcium. And I think, once again, always think about a combination of foods to achieve good levels of these things. I've mentioned fiber, some other superfoods. I've mentioned the flax seeds, whey protein, soy. Soy is a phytoestrogen. Phytoestrogens, flax seeds contain phytoestrogens too. Phytoestrogens mean plant estrogen. Looks kind of like estrogen, but it's not. What it does is it actually binds at our estrogen receptors and keeps off more stronger forms of estrogen. This is good because there is always a bit of we want to check off the really strong stuff, but still have the receptors getting enough of a message that it's actually capable of helping with some symptoms. So soy and phytoestrogen consumption has actually been studied and it seems to be helpful when women have hot flashes and night sweats. It seems to help with overall symptom scores. It also seems to be very heart protective. And in general, it is a myth that phytoestrogens increase breast cancer risk. It's a myth. Once again, even the word estrogen scares a lot of women when we talk about breast cancer. Phytoestrogens are not estrogen. They actually seem to be protective, if anything. So don't shy away from those foods. So there's so many good things to include, right? Hopefully this makes you feel like, oh, it's not like extremely restrictive, right? I'm not suggesting any kind of extremely restrictive diet. And I'm not saying that there isn't ever a time or a place for, you know, a paleo diet or, you know, a high fat diet, or, you know, I just think broadly speaking for these purposes, and like in general, the kind of, I'm talking about a variety of foods. I'm really talking about in general, a Mediterranean style diet. So if you're like, what is that? It's a lot of what I've already been talking about. It's mostly plants. It's the use of animal products more sparingly. It's minimal sugar and alcohol. It's those basics put together. So if you wanted a visual, I like this visual. When I looked at this, I was like, yeah, that's what you want to be eating. Veggies, fish, nuts, seeds, beans, spices, fruits, right? You can see different color, different texture. You know that there's fiber there. You know that there's protein there. So you strike that balance, and it's not about being perfect. Life's too short. Food is pleasure with me. Like, I love eating. And I don't want to go through life not being able to eat out, right? Or treat myself. I do not live in a way where I restrict, but I do try to achieve this being the base of my diet 75 to, 90% of the time. And I think we just need to come back to this and make this accessible to more people. This is the Mediterranean diet pyramid. So this is so beneficial when we're talking about your heart health. It's beneficial when we're talking about weight management. It's beneficial when we're talking about blood sugar management and diabetes risk. It's even beneficial for bone health. So if there was one, I hesitate to say the word diet, or I'm going to say style of eating or nourishing yourself, it would be this. I come to this every time. It's really well studied. And we know that a lot of people that live the longest really well and independently, this is how they eat. So they live in Greece, they live in Sardinia, they live in all the countries that line the Mediterranean. So even North Africa, around like Lebanon, Israel, they all have their own sort of different cultural styles of this. And, certain local ingredients, but at the core, this is what those diets are. You can see they're mostly plants. They eat more seafood and fish, and then they moderately eat chicken, eggs, dairy products. Meats and sweets are really pretty much just celebratory. So it really is, it's pretty simple. But I love it. I come back to it every time. I try to really keep this center in my lifestyle, and I think a lot of women I work with benefit from it too. This image here is showing you, this is phytoestrogens. So soy, lentils, any kind of pulse or bean, flaxseed, once again, any soy product contain phytoestrogens. Do not fear them. They're great. They're great for protein. They're great for fiber. They're filling, right? They're regulating for blood sugar. And they have the added benefit of having that effect on our estrogen receptors, and actually, if anything, being protective there. So it's a win, 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 win. So diet, we've talked about that. I mentioned the stress piece and how that is kind of like throwing gas on a fire in a lot of ways. I've mentioned it's not realistic to say we cannot have any stress. We're all going to have stress. Life happens. Talk about the last year, which is just like a blur, right? We do have to appreciate, like, okay, how much am I putting on my plate? What am I saying yes to? What am I saying no to? Or what should I be saying no to because it just drains me even more? How can we reframe our expectations of yourself, of others? We need to practice, I think, more self-compassion. This is the idea of, like, I think myself included, like, I'm so critical of myself, but it's easy for me to say something nice to a friend or someone else and be like, look at you, you're doing so great. Look at all you've done. But I can't say that to myself. No, forget it. I think we need to practice more of that as women. And it's not easy. And I'm saying that as someone who does not have it consistently yet, but I'm working on it. I do think that drives a lot of stress in women. We need to practice. We need to use our brain like any other muscle. And if we practice more gratitude, and we practice more mindfulness, and we practice deep, slow breathing. It's like any other muscle. We just need to use it. We have to be consistent, and then it becomes more easy to access. And we know that it helps to decrease cortisol levels in our body. So it's protective, but if we don't use it, it's kind of like you use it or you lose it, right? Often it's like easier for our brain to go to the negative, or go to the limiting beliefs, right? Or whatever it is. So once again, I'm saying this as someone who's not doing it perfectly in any way, but I'm working on it. Got to ask for help. Community, this is a big one for women. So the fight or flight response when it comes to stress, that's a very male predominant saying, fight or flight. In women, it's actually been suggested that women in times of stress actually tend and befriend more. So they reach out more to community. They reach out more to people around them. And I think that's amazing. But we have to think about, like, am I really doing that? Obviously, COVID has presented really a challenge in the way that we do this, because we can't physically do it. But I still think it's really good to remind women, like, it's actually in a woman's core to want to reach out more. And it's important that we do that so that we don't feel alone. Move, rest, breathe, sleep, nourish your body, get support for all these things if you need it. There's lots of people, myself included. This is what I help women with. This is what I support women with, working on. And try to think about, like, what's in your day and in your life that really just feels like it fills your cup. What brings you like a sense of like childlike joy? Just what makes you happy and makes you feel free and light, right? Can you have a little bit more of that in your day to day? That will literally take your cortisol from here to here. And that's good. I wanted to mention too, activity wise or movement wise, as we age, once again, we're more likely to lose muscle quicker, and we want to keep as much muscle as we can. So we need to remember that women need to focus on building and maintaining muscle mass. Any kind of movement is great for so many reasons, but women can also benefit from having certain resistance training or weight training. And I think, that has to be maybe worked out. Maybe if you have a certain injury, we need to figure out how exactly you could do that and what's safe and won't aggravate injuries. But you want to think about how can you work big muscle groups, right? How can you work your butt, your quads, your legs, your hamstrings, your abs? We need to work those muscle groups, and that helps us maintain them. The more muscle we have, the better off we are. And in general, if we're thinking about weight as well, there is research that says that if we do higher bursts of high intensity activity, it shows that there's a bit more bang for your buck on a weight loss point of view. So like compared to slower, maybe more longer forms of movement, I just encourage women. I'm like, whatever gets you moving, you got to do something you like. You've got to ideally do it consistently. So whatever it is that works for you, you've just got to do what works for you and what you actually like. Do something you like. If you don't like it, you won't do it, right? It's as simple as that. You'll do it for a while, but you won't stick with it. Okay, bone health. I promise I'm going to stop talking soon, but I do want to make some mention about bone health because it matters to women. So osteoporosis, which is a condition in which the bone has basically thinned out and become much more susceptible to breaking or fracturing. It can affect people at any age. Rickets was a condition that used to be diagnosed a lot more in kids, and that was decreased bone density in kids. It was really caused by nutritional deficiencies, which we really don't have anymore because of understanding of that and putting these nutrients in foods and supplementing and whatnot. But osteoporosis can affect people of any age, but it really more commonly affects Canadians 50 and older, much more common in women as well. So this is a very big women predominant condition. At least 1 in 3 women will break a bone due to osteoporosis in their lifetime. So that's some of you here. Fragility fractures, which are common in the hip, the wrist, or the spine, represent 80% of all fractures in menopausal women over the age of 50. And fractures from this are more common than heart attack, stroke, and breast cancer combined. So it's more likely of any of those other things that you'll break a bone than you will of any of those other things. Now, not as many women are dying from breaking things, but it's still a cause of disability in women. So it needs to be talked about. Now, breaking a hip, unfortunately, people living with osteoporosis, if they break a hip, the older you are, the even worse outcome it is. It shows almost 30% of women who suffer a hip fracture will die within the following year, which is like sobering number. So we know that there's a reduced quality of life, lowered self-esteem. There's a loss of mobility that comes with breaking something. There can be disfigurement, right? There's a lot of fallout from breaking bones as we age. So it matters. This needs to be talked about. Usually it's considered a silent thief, right? In the sense that your bone loss is deteriorating and you don't necessarily feel it until you actually break a bone. So the risk factors, once again, are just frankly being a woman that is aging, being a woman that goes through early menopause, once again, accelerates bone loss. So there's research around like the more menstrual cycles you have, like the longer you have menstrual cycles, it's actually you have more cardiovascular protective effects and bone protective effects than when you once again lose your period early, which sometimes happens, but women just need more support when it happens. Surgically induced menopause is a bigger risk factor. Breast cancer treatment is a bigger risk factor for bone loss. Taking steroid medications, once again, anyone with autoimmunity, maybe they need to take steroids to suppress inflammation. Unfortunately, steroids affect bone mass. Acid blocking medications, so treatment for GERD or reflux, taking those long term, those are called like Nexium or any of the omeprazole, things like that. Their long-term use blocks your stomach's ability to absorb calcium, magnesium, other minerals, and that can affect bone health negatively. If you are taking Synthroid or basically thyroid replacement hormone, if it's over replaced, that causes accelerated bone loss. So you need to check in on those levels when you are. Autoimmunity, inflammation drives more bone loss, unfortunately. Basically not moving your body or bearing a lot of weight is a risk factor. Having a low body weight is actually a risk factor for more bone loss. So women that are a bit heavier are actually better protected against bone loss because there's more weight on their bones, and weight on your bones actually stimulates bone remodeling or growth. So that's a factor. And then nutritional deficiencies, so low vitamin D, vitamin K, calcium, magnesium, even vitamin C. There's some other minerals as well, like boron, that have been researched. So there's a combination of nutrients that matter too. Whatever increases the risk of falling in women increases the risk of fractures and therefore long-term disability. So there's like research looking at like alcohol use and risk of falling. There's research looking at women that need to take sleeping pills for long periods of time, and that increases risk of falling. So those things need to be understood too. The way that we actually diagnose osteoporosis is, like, once again, some women, it's like they'll break something, and then, you know, if they're postmenopausal, often their doctor will be like, okay, we're going to do a bone scan in the near future to actually figure out what your bone mass is. So this is called the Dexa bone scan. It's X-ray imaging that actually determines the density within the bones. And usually it measures it in your neck, in your lower back, in your lumbar spine, and in your hip. And basically it's scored by looking at kind of how far away you are from like peak bone density. We all have peak bone density when we're, I would say, when you're about 20. So for women after the age of 20, your bone is going downhill for a long time. It's seriously sped up when you go through menopause, and then after, but basically it's going downhill throughout our reproductive years. And we're comparing sort of the ideal to where you're at now. And that correlates to like, okay, you have thin bones at this point, or lower bone density. I wanted to make mention of vitamin D. Vitamin D, I think, is a really important thing for bone health and so many other things. In general, if our vitamin D is low, vitamin D functions as a hormone. It affects calcium absorption in the gut. It increases muscle mass. It supports that. It increases muscle strength. It decreases falls. There actually been studies showing that vitamin D deficiency, people fall more and then they break more bones, right? So there's a lot of different ways it's involved. I'm showing you an image there of some of the foods, notably, that you can get vitamin D from. So seafood, mushrooms, egg yolks. We also make vitamin D in our skin when we're exposed to UV light from the sun. I test this in people and their blood level, and I typically find most Canadians, I'm in Canada, if there's anyone here that's not, most Canadians are going to be low on their vitamin D, despite being exposed to the sun and also despite supplementing in some cases. If we test in your blood level, then I know how much you ought to take from a supplement. You can take too much vitamin D. So testing matters here when it comes to understanding what's the right level for you. What do we need to go for to actually achieve the protective effects on your bones, on your muscles, on your heart, on so many other things that vitamin D has benefit for. So eating well for bones, once again, I'll say like a Mediterranean diet is really good for bones. A plant predominant diet is really good for bones. In general, it's really nutritionally dense. It doesn't drive as much inflammation from my point of view as animal-based foods do. And more inflammation will accelerate more bone loss over time, for sure. We want to have optimal protein intake. Protein is really important for your bones too. Your bones are made up of protein. You want to eat a variety of mineral-rich foods, calcium, yes, but things like magnesium too, and zinc, and just once again, a combination of plants, nuts, seeds, beans, pulses, dairy, fish, the occasional meat. Like, you'll be well-rounded if you do that, right? So anytime people have to cut out big food groups, right, or categories of food, you're at risk for nutritional deficiency. So I'm always trying to help someone be able to eat a big variety of foods because that's the healthiest. We want to have a smart consumption of caffeine, alcohol, and sweetened drinks. In general, all these things in excessive amounts will accelerate bone loss through different mechanisms. Eating for optimal gut bacteria. I haven't mentioned this yet, but healthy gut bacteria, which we all have bacteria all throughout our colon. They help us absorb calcium and other minerals and send them to the bones. So it's really important, those gut bacteria. You might not think of gut bacteria for bones, but they matter. And the biggest way to feed them and keep them happy is to eat lots of fiber. So once again, lots of plants. Get your vitamin D tested. I've mentioned that. It's a simple blood test. It's about $40 to $50, depending on where you get it done. And sometimes if it's known that you have bone disease or osteoporosis, or you've had low levels on testing before, then OHIP, where I am in Canada, will pay for the test. But if you've never had it tested, you have to get it tested once, and then it'll be, you have to retest it. Usually annually, I have people retest it so that we're keeping track on people's level. And the other thing I'd say with respect to bone health specifically is consider combining vitamin K2 with vitamin D. And that's because there's some more and more research coming out that says vitamin K2, which is what we call another fat soluble vitamin, in that amount, 30 to 50 micrograms per day, is quite protective to bone density and what's called resiliency. So bones where women take vitamin K combined with D, if they fall, they're less likely to break a bone, which means your bone is like better able to resist impact on it, right? Which is interesting. So that's worth mentioning too. Now, hormone replacement therapy, just quickly, there is research that says giving women estrogen right around the menopausal transition or that last final menstrual period is absolutely the most effective preventative strategy it is. There are other treatments that are recommended to women that are not hormones. A lot of them are called bisphosphonates. They have bad side effects, unfortunately. And I see that they are more commonly recommended these days than hormone replacement therapy is for bone health. But I just think it's worth mentioning that this is an option that you should bring up if you want to. So that's taking estrogen replacement, usually combined with a progesterone. It's also a reasonable treatment for diminishing or slowing the progression of what's called osteopenia, which is basically like the precursor to osteoporosis, which is like now your bones are thin. So osteopenia is like you have thinner bones. And once again, bone scans actually confirm if that's going on, but estrogen replacement does seem to be protective and slows it down. Research shows that estrogen replacement reduces the risk of hip fractures by 30 to 50%, which is pretty significant. And replacement therapy for bone health is ideally, once again, started close to that final menstrual period, not like 10 years after, because the bone loss accelerates right around your last menstrual period. And then it slows down again, just like weight, just like cardiovascular changes, right? So it's always great to try to get women in that window. And it's the most protective and the least amount of risk, I would say. The other thing I want you to know is that you basically, HRT is best continued longer term for bone mass benefits. So basically, if you take it for 3 years and then stop it, the effect on your bone health, like it might have slowed down a very quick acceleration of loss, but it doesn't stay. You have to kind of keep taking it to have continuous protective effects. And it doesn't, not every woman wants to do that, right? Maybe because of cost, because they don't want to apply the hormones or whatever it is. You just have to have that conversation with whoever you're working with on that front. Okay, I promise I'm almost finished. I wanted to make mention once again of testing. I know this came up in the last presentation, but I'm a big believer in helping women when they come to me, perimenopause, menopause, post-menopause. If they haven't done some blood work or just had a good, thorough sort of physical health check-in, I'm like, this is the time, because there's so many changes happening, right? That we've talked about: bone health, heart health, brain health, sleep, blood sugar, right? All these things. I'm like, this matters. We need to give you a pulse on how you're doing, right? And the good news here is I love going over blood work with women because I can tell them where they're at. And I'm like, this is so cool because now I know I can take you from here to here by doing X, Y, and Z, right? Like, it should be motivating and empowering. And a lot of women, they get blood work done or some blood work, but their doctor doesn't, follow up on it, or they say everything is fine or normal. And that doesn't always amount to, women are like, I know you say that, but I don't feel fine or normal. And there's no sort of just increased awareness or understanding that comes from that. So I guess I have the time to do this with women and talk about it more. This is a subjective tracking tool, which just means you're scoring your own symptoms. I give this to most women that I work with. You can see there's questions around hot flashes, heart discomfort symptoms, sleep problems, anxiety. I use this as a tool, and every couple of months we'll check in and like, hey, how are we doing? Were you severe more often than not, and now you're moderate? Great, now you can see this, right? There's so many different ways of achieving that. It's not always using hormones. It's just that we want to track things better, right? Then you understand your experience better. So blood work wise, checking fasting blood sugar, insulin, and A1C, and calculating something called a HOMA-IR score is a very good way to give you insight into your metabolism and why you're hanging on to weight in the midsection. So I run these tests a lot. Once again, I can look at your insulin level and tell if it's higher than it ought to be, and then we can make strategies around how to lower that, around how you eat, certain supplements sometimes, a number of things. Checking your thyroid completely, complete blood count, red blood cells, white blood cells, iron levels that came up with respect to energy, low energy concerns, vitamin B12, vitamin D. I mentioned that. You got to test it. We can't guess when it comes to vitamin D. We got to test it. Cholesterol panel, CRP. This is C-reactive protein. This is a very good test to do for cardiovascular health because it is a good marker of general inflammation and inflammation within the blood vessels. So I do run it a lot to help. It doesn't tell us where inflammation is coming from, but we kind of just want to have a touch point for it so that when we, whether it's diet changes, supplementation, addressing a gut health condition or an autoimmune condition or whatever it is, we want to see that CRP come down over time. It's a cheap test. I do test it a lot, and I see doctors testing it too. Liver and kidney function tests, not a bad thing to include on baseline blood work. And then there can be other tests, right? These are a lot of common things I run as part of sort of baseline testing. A lot of doctors do too. There are other tests that, once again, on a case-by-case basis, we might need to add in. But these are really core. Bone scan. So that's the x-ray that really tells you about your bone density. All women should have this done by the time they're 65. Some women, if like they've had a fracture and they were 45, or if they went through menopause early, or they're like, my mom had osteoporosis and she broke her hip, doctors will order this sooner for women that have heightened risk, but definitely by the age of 65, it should be done. Just to make mention, PAPs, they should be done every 3 years until you're 70. Mammography, every 2 to 3 years, and I'm in Canada, so the guidelines, if you're not in Canada, might vary, but in Canada, the recommendation is you have a mammogram every 2 to 3 years from the age of 50 to 74. It used to be earlier, so they used to recommend more mammograms in women 40 to 49, but there were more false positives, meaning your breasts are more likely to be dense when you're in your 40s, and that causes more things that look suspicious, and then there was unnecessary surgery or treatment associated. So the guidelines have been revised. But every woman, if you have lumps or bumps or you feel something, always go to your doctor about it. Transvaginal ultrasound, that's looking up into the pelvis and the uterus. Any post-menopausal woman, so if you have not had a period in a year and then you start bleeding, vaginal bleeding, you must see your doctor about it. We have to rule out cancer first. So I don't mean to scare you, but endometrial cancer is the first sign of that, is post-menopausal bleeding. It doesn't mean it always is, but we just need to check for it. So you need to have an ultrasound to assess any bleeding. If you've gone a year without a period and then you have bleeding, you have to tell your doctor so that you can have a transvaginal ultrasound done. And blood pressure. I mean, we've talked about cardiovascular health. I think every year women should check in on her blood pressure with a doctor. Some women, if they know they have slightly higher, they might be doing it at home, and then you have to check in with your doc again on that. Okay, so I've talked a lot. I could talk so long about this, but I'm going to wrap it up now. I want women experiencing menopause to acknowledge, it is a natural transition. You are at a crossroads between feeling often confident and wiser with your age, but you end up feeling depleted and not like yourself. And, you're not sure who's looking out for you here, it's unfortunate. Women want to feel like the menopausal transition is a bigger consideration often when they bring it up with their healthcare provider, right? That it's not sort of checked off as just well, this is what happens when you get older. Well, this is just because of menopause, right? It's not wrong, but it's not helpful to say that. There are so many things we can do to support a woman in feeling better, in feeling more in control, in feeling more empowered about it. We just need to start talking about it more. I really think that's key. The change is impactful, right? It affects women's quality of life, absolutely. So we need to talk about it more. We need to take it more seriously. By understanding what is happening in the body, you can start to build a wellness plan that is proactive and preventative, but also responsive to the change. So it's never too late. So if I'm talking to someone here that's 65, it's never too late to talk about these things and want to, promote your health now that you're, well into being postmenopausal. And wherever you are, women, we can start talking about this. You can have a significant impact on how menopause affects your life with better, proper guidance and support. And that can be so many different things. So I believe this is important because I think I really believe the more women we support, women do amazing things. And there are so many menopausal women doing amazing things and literally holding the world up. I believe that. And I just want to keep seeing this being a conversation, a bigger conversation. These are some good resources. The North American Menopause Society I'm a member of, they have lots of good resources for women and the public. Estrogen Matters is a really interesting book that talks about why basically the risk of hormone replacement was really overblown and inaccurate, and how, as it says there, taking hormones in menopause improves women's well-being and lengthens lives without raising the risk of breast cancer. So they're really debunking a lot of that research that scared us away from using hormone replacement therapy. Mokita is a great book about perimenopause, and Shirley Weir, the author of that book, has a fantastic online community. That's just great. I would say she's a real champion of changing, just making women talk about this more. So it's great. I've made a couple other notes there about certain books. But yeah, I'm going to leave it at that. And I welcome women to ask any questions, which I'll take quickly. If you need to tune out, you can. The recording will be available shortly on the YouTube page. I just want to thank you all so much for coming. listening and caring about your health. Yeah, women matter. And I think, once again, women often feel even more devalued when they go through menopause and as they age, and society and the media and all these different things factor in. And I'm like, we got to change that. We got to change that, because we have so much to offer. And I would argue that going through menopause only helps us have even more to offer. But I think a lot of women don't feel that way. So anyways, thank you for coming. I will stop for now. Just checking the chat here. And thanks again to the Collingwood Public Library, to Lori, to Gordon, who helped set this up and run the tech side of things. Yeah, I can be found. My website is there. My email is there. If you want to reach out to me after with any questions, feel welcome to use that. I'll leave this up for a minute just so that you can see that. But otherwise, we'll leave it at that for today.